Welcome to the Explainer. Today, we are tackling a complaint you'll see pretty much every single day in clinic, the stuffy nose. We're going to build a really practical framework for diagnosing rhinitis, one that helps you get from a super broad symptom to a specific, actionable plan.
Okay, let's dive right in. Here's our game plan for today. We're going to start by just defining our terms. Then we'll walk through the most common types of rhinitis, look at some of the sneakier culprits, and then wrap up with the really critical stuff, the red flags and when to refer. It's all set up to follow how you'd think through a case.
All right, first things first, we have got to be precise. You know, in medicine, clear definitions are everything. So let's build our foundation.
So it's really important to get this. Rhinitis isn't just a stuffy nose. It's a clinical diagnosis, and it's based on this specific group of symptoms. If your patient comes in with at least one of these four, sneezing, a runny nose, congestion, or that classic nasal itching, that's when you should start thinking, okay, this could be rhinitis.
And right away, you have to make a key distinction. Is it just rhinitis, inflammation in the nose, or is it rhinosinusitis? The big difference here? Sinus involvement. So if your patient starts talking about facial pain, pressure, or that thick, nasty, purulent drainage, your focus needs to shift to the sinuses. That's a whole different diagnostic path.
Okay, so we've got our definitions down. Now let's get into the diagnosis that probably jumps into everyone's mind first, allergic rhinitis. And, for good reason. This one is a huge player, especially in some patient groups. And when I say huge, I really mean it. The numbers are just staggering. Up to 40% of all kids are affected by allergic rhinitis. Think about that. That's almost 1 out of every 2 children you'll see in a pediatric clinic. So yeah, this is a diagnosis you absolutely have to master. Now take a look at this list of symptoms. Something should really jump out at you. While all of these are pretty common, that nasal itching is the real giveaway. It is the single most specific symptom that points you toward an allergic cause over all the other types of rhinitis. So if the patient says their nose is itchy, your brain should immediately scream, allergies.
And when you do your physical exam, especially on kids, you're going to see some classic signs. First up, you have these allergic shiners. That bluish-gray shadow under the eyes, it's not because they're tired, well, not just because of that. It's actually from chronic venous congestion because their nose is so blocked up all the time.
And here is the other dead giveaway you'll see, the allergic salute. It's that classic move where kids are just constantly rubbing their itchy nose upward, trying to get some relief. And if they do it enough, over time, it can actually create a little horizontal line, a crease, right across their nose. If you see that crease, it's a huge clue that itching has been a big problem for a long time.
And hey, don't forget to actually look inside the nose. Your otoscope is an incredibly powerful tool here. With allergic rhinitis, the mucosa is going to look pale, kind of boggy and swollen. It's a night and day difference from the angry, beefy red you'd see with a viral cold, or, interestingly, from overusing decongestant sprays. But, of course, not every runny nose is an allergy, right? So, let's explore the world of non-allergic rhinitis. This is a diagnosis you'll find yourself making a lot, especially in your adult patients. Honestly, your best tool for telling these two apart is just a good history. Allergic rhinitis usually kicks in earlier in life. The main complaint is itching, and it's set off by things like pollen or pet dander. Non-allergic rhinitis, on the other hand, tends to show up later. Congestion is the big problem, and the triggers aren't allergens. They're irritants like perfume, smoke, or even just a blast of cold air. Okay, now here is a super important clinical pearl. Real life is messy, and a lot of your patients aren't going to fit perfectly into just one of these boxes. Turns out, mixed rhinitis, where they have a combination of both allergic and non-allergic triggers, is actually the single most common type of rhinitis in adults. So if the story sounds a bit like both, it probably is.
So we've covered the 2 big categories. But now it's time to put on our detective hats and think about some other, more specific things that can look just like rhinitis.
Listen, you have to check the medication list. It's amazing how many common drugs can cause rhinitis, and it usually just shows up as pure nasal congestion. Antihypertensives are major offenders. Think beta blockers and ACE inhibitors. But also keep an eye out for erectile dysfunction drugs and even certain psychotropics. And speaking of medications, we need to talk about a condition that we, as clinicians, can sometimes cause. It's called rhinitis medicamentosa,
and it's a wicked rebound congestion that happens when people overuse those over-the-counter decongestant sprays.
And this slide just perfectly lays out the trap people fall into. They use the spray, they feel better, but then it wears off and the congestion comes roaring back, often even worse than it was before. So what do? They use it again and again, and they get stuck in this awful cycle of dependency. This is why we have to educate our patients. These sprays are for short-term use only, 3 to 5 days max.
And don't stop there with the history. Ask about their job and their social life. Do their symptoms magically get better on the weekends? You should be thinking about occupational rhinitis. Are they in their 3rd trimester? It could be rhinitis of pregnancy. Do their symptoms flare up after a glass of wine? That vasodilation from alcohol can be a direct trigger for congestion.
All right, and finally, we've arrived at what might be the most important part of this whole framework, knowing when to worry, figuring out what else this could be, and knowing when it's time to call for backup.
This is the question that should always be humming in the back of your mind. Look, most rhinitis is totally benign, but you absolutely cannot afford to miss those rare cases that are pointing to something way more serious. So here they are. These are your non-negotiable red flags. The absolute biggest one is persistent one-sided symptoms. Rhinitis is almost always a bilateral issue. If it's only happening on one side, you have to start worrying about a structural problem, like a polyp or even a nasal tumor. Also, pay close attention to recurrent nosebleeds, a sudden loss of smell, or any clear, watery drainage after head trauma, because that could be a CSF leak.
So, how do you decide who to send them to? It actually boils down to the question you're trying to answer. If you're pretty sure it's allergies and the patient could benefit from formal testing or immunotherapy, that's an easy referral to allergy. But if you're worried about the structure, if you've got those one-sided symptoms, or if you're just not sure what's going on, that's when you pick up the phone and call your friendly neighborhood ENT surgeon. So there you have it, a clinical framework to help you take that super common complaint of a stuffy nose and break it down into a much more precise, actionable diagnosis. So my question for you is, the next time a patient comes in with rhinitis, what's that one key question from their history or that one finding on their exam that you're going to look for?